So, all right then. So welcome to the Department of Medicine Grand Rounds today, this March 28th. And we are delighted to have a visiting professor today. And to do the honors, I'm going to kick it over to Dr. Srinivasan for the introductions.
So thank you, Wendy, and good afternoon, everyone. It's my pleasure and honor to introduce Dr. Jason Dominitz, our Grand Round speaker today. So Dr. Dominitz is the Executive Director for Gastroenterology and Hepatology in the U.S. Department of Veterans Affairs. He's a professor of medicine at the University of Washington, and he joined the VA Puget Sound in Seattle, in Washington in 1997 after completing his residency and a GI fellowship at Duke University. He also has a master's degree in clinical research from Duke. Dr. Dominitz has a long-standing interest in colorectal cancer screening and management. And during his GI fellowship, he did a study on patient preferences for colorectal cancer screening and conducted a study on racial differences in preference for colon cancer treatment. So his interest stemmed really early on during his fellowship. Currently, he co-chairs a 17-year randomized prospective VA cooperative study comparing screening with annual FIT compared to screening colonoscopy in 50,000 average risk veterans, which is called the CONFIRMED study. And Dr. Dominitz has co-authored over 250 peer-reviewed publications, guidelines, and editorials. Very recently, in 2022, Dr. Dominitz established the VA National Colorectal Cancer Screening Program. This is a nationwide screening of colon cancer screening program, and I'm sure we're going to hear more about it today. And most recently, many of you have heard about the editorial Dr. Dominitz wrote about the Nordic trial as it relates to colon cancer screening in Poland, Norway, Sweden, and Netherlands. And I'm sure we're going to hear more about that today. This is for the New England Journal article that I'm sure many of you have heard about. So without taking much more time, I'm going to turn it over to Dr. Dominitz for his talk titled Challenges in Implementation of Colorectal Cancer Screening. So thank you.
Thank you. So we play musical chairs here. Thanks to Dr. Srinivasan and Dr. Christie, Dr. Goebel, everyone for inviting me out here to speak with you today about my favorite topic, colorectal cancer screening. It's great to be with you all here today. I wish we could be in person. It's always much more fun to talk to people face to face, but we do what we have to. Oh, sorry, I thought that, yeah.
Go to the disclosures, yeah.
Okay, sorry. Believe you're seeing my screen now.
Looks perfect.
I have no disclosures. So colon cancer is the second leading cause of cancer death, with about 153,000 cases this year and 53,000 deaths. These numbers, they're huge numbers, although we're getting used to, or at least I feel like we're getting used to hearing bigger numbers because of the pandemic. But I really want folks to put those aside right now and think about what 153,000 people looks like. It's such a common disease, and it doesn't need to be, because screening is effective and cost effective. And I want to talk to you today about some of the challenges we're facing as we see, again, 53,000 people dying of colon cancer in a given year. The epidemiology of colon cancer is changing. Cases in those under age 55 have increased from 11% in 1995 to 20% in 2019. It's an epidemic of early onset colorectal cancer, and there's a shift toward left-sided colorectal cancer. It's not clear why this is going on. There's a lot of research going on to try to understand this. There was a recent paper in the last week or so looking at maternal exposure to dicyclamine as a potential causative factor in some of these cases. There is some good news. We are seeing a decline in mortality by 2% per year from 2011 to 2020. However, mortality is increasing in those under 50 and in Native Americans younger than age 65. More than half of the cases and deaths of colon cancer are attributable to modifiable risk factors, including smoking, diet, alcohol, inactivity, and obesity. Here we see the trends in cancer incidence, all ages in the upper left-hand corner. You see that the trends are coming down, but for those under 50, they're going up quite markedly. So the U.S. Preventive Services Task Force gives us a number of screening options. Yesterday at GI Grand Rounds, I talked about those options in some detail. I'm afraid I'm not going to be covering that today. And so during the Q&A time, if there are questions, we can try to get to those. But we have a number of options available. And in the VA where I work, we have had good success with getting colon cancer screening completed. Over 80% of veterans were up to date with screening based on the chart reviews that have been done for many years. But at the start of the pandemic, and even a little before the pandemic, we started to see these numbers decline. And I want to go through a little thought experiment with you. I suspect if I was able to poll all of you and asked you what screening should we offer people, most of you, if not all of you, would recommend screening colonoscopy. And I'm a gastroenterologist. I love screening colonoscopy. I was interested in screening colonoscopy as a fellow before screening colonoscopy was really a thing. It was in the 90s, and screening colonoscopy wasn't fun. It wasn't approved and covered by insurance until 2000. But think about if you were working in a VA healthcare system like I do, where we have 6 million veterans that we're responsible for, and we look at how many are due for colorectal cancer screening in the next 90 days. So we ran this data a couple of weeks ago for this talk today, and there's 203,000 veterans that we would need to get screened in the next 90 days. So can we do 203,000 screening colonoscopies? Well, there's also another 230,000 who were due in the last 3 months that are not up to date with screening at this time. So now we've more than doubled that number. And we have a bunch of people who are overdue by up to a year or 1 to 2 years or more than 2 years. Now, many of these people have decided not to be screened for whatever reason, but we want to get them in. We want to offer them screening and get it completed if at all possible. So this totals over 1 million veterans who are due for screening today, due or overdue. There's another 182,000 who are going to be due between that 90-day mark and the end of the fiscal year. So while I love screening colonoscopy, I don't think we can do that many screening colonoscopies. We also have 26,000 people who are FIT positive who need to get a colonoscopy. And we have 475,000 surveillance exams that are due or overdue this year. Next year, we know 275,000 people will be due for surveillance colonoscopy because we track that with our reminder system. The VA, before the pandemic, did 280,000 colonoscopies a year. So just the surveillance exams alone, let alone FIT positive or screening, would take up our entire capacity. So you add it all together, and it's just not tenable to offer screening colonoscopy. So here you can see the impact of the pandemic. Colonoscopies are in blue, and you can see our numbers per month before the pandemic. And then in March of 2020, we went down to almost 0 colonoscopies. And now we are only at 75% recovery. So our volumes are down 25% from before the pandemic. So the last time I was in Atlanta was in 2019 when I was part of a CDC summit on mailed FIT. And we were looking at ways to improve population-based screening. And so I was thinking about this even before the pandemic hit, but when the pandemic hit, it became clear we had to do something else. If you look at the orange bar here, these are the number of FIT tests completed per month in the VA. And note where the red arrow is the dramatic drop between March and April of 2020. As you know, patients stopped coming into clinic, and it was in clinics that we handed out FIT kits. So we needed to come up with another way to get kits into the hands of veterans so they could be screened. And here, sorry, there you go. In 2022 and 2023, you see that our volumes of FIT completion exceed those of the pre-pandemic levels. We went from about 400,000 FIT per year before the pandemic to 474,000 last year. So a pretty significant increase. But this was not with programmatic screening. This was just through encouragement, through memos, through a lot of talks that I gave and others gave around the country to increase the use of FIT screening. So I wanted to review with you the screening process and where there are challenges. When you're in a clinic visit or when you think about population-based screening, you start with offering screening, and it's either negative or positive. If it's negative, you offer screening again at some interval. If it's positive, you do a colonoscopy, or you can go straight to colonoscopy as the first screening test. Colonoscopy either finds cancer or it doesn't. If there's neoplasia on colonoscopy, then we do surveillance at 3 to 10 years typically. If there's no neoplasia, we go back to offering screening typically again in 10 years. But while this may sound simple, it's not so easy, and we really do need an easy button for this. because there are challenges. Sorry, I'm having a little technical difficulties. It's not advancing my slides. There we go. Who do we screen? How do we screen? How often? What cutoffs? And is the quality of the colonoscopies adequate? And I'm going to touch on these points over the next 45 minutes. Chaik Dubeni has published this nice overview of the screening process and where it can go wrong. And I'm going to touch on these failure points. So I'm having a little bit of an IT lag here.
Use the keyboard.
Yeah, I try. Yeah, so you can see that there's failures at each of these parts in the screening process. And really our goal is to try to think about this from a quality improvement perspective and minimize these failure points. So I'm going to cover each of the topics shown here. For the sake of time, I won't go through them. Now, the first issue we have is that screening adherence is not where we want it to be. Now, colon cancer screening adherence, as you see here, has been improving over time, approaching the levels we see for breast and cervical cancer screening. There was a goal from the National Colorectal Cancer Roundtable to get 80% of Americans screened by 2018. We've fallen short of that target. More recent data that I've seen preliminarily is that we're plateauing around 70%. We'd really like to get those numbers pushed up and pushed up in every community, not just as averages, but in all racial, ethnic groups, urban, rural, et cetera. So to whom should we offer screening? The U.S. Preventive Services Task Force updated their guidelines in 2021. Previously, they gave a grade A recommendation to adults aged 50 to 75. But 2 years ago, because of that epidemic of early onset colon cancer I mentioned a few minutes ago, they have recommended that screening begin at age 45 to 49 with a grade B recommendation. Sorry. They recommend individualized screening in people age 76 to 85 and no screening beyond age 85. So really, if you're dealing with somebody who is 76 to 85, you want to think about their prior history. If they've had a FIT done every year for 25 years and they are, really healthy running marathons, you might consider giving them more screening, or you might say that, their chance of having colon cancer is pretty low. If they have significant comorbidity, then probably no role for screening. If they've had a colonoscopy at 50, 60, 70, you probably don't need to do it again at 80. Now, I think it's important we think about how screening occurs in the US. Most screening occurs in what's considered the opportunistic setting as opposed to an organized screening setting. And I want to focus on the difference between these two. So opportunistic screening is where the provider decides who to screen, typically during a clinic visit. They decide what test to offer. Often they're offering colonoscopy. They're responsible for dealing with the follow-up of results. So if it's a FIT exam, a fecal immunochemical test that's abnormal, they will be responsible for the follow-up. And the quality assurance is highly variable. In an organized program, the program decides who's eligible for screening. They can do screening independent of clinic visits. They can offer screening to people while they're at home. You don't need to be at a doctor's office to make the decision that this person is now due for screening. The program determines what screening is appropriate for the program. Often it's a FIT test, but a provider can offer an alternative. So if your patients have FIT mailed to them, and many insurance companies now do this, Blue Cross, Aetna, United Healthcare, they have implemented programs of mailing FIT kits to people to get their HEDIS measures improved. You could still offer something else like a colonoscopy if you wanted to. The program has tracking registries to augment provider action, so to make sure FIT positive people are followed up, for example. And then there's typically quality assurance programs with benchmarking and registries to make sure that outcomes are what they hope to see. And I'll give you an example of this in a little bit. So it seems pretty straightforward. You define the inclusion criteria like age 45 to 75 and exclusion criteria like people who have had prior screening like colonoscopy or fecal immunochemical testing. And then you build in processes to avoid underscreening, like find patients who have a history of adenomas or a family history or symptoms that warrant colonoscopy. I apologize, we're still having some lags with the screen here. But you also want to avoid overscreening. So you can have patients who have had a prior colonoscopy And you need to know what the results were to avoid, for example, you don't want to send a fit kit to somebody who had a normal colonoscopy 5 years ago, or you don't want to send a fit kit or order a colonoscopy on somebody who has significant comorbidities, especially hospice or metastatic cancer. So there are challenges in this cohort identification. Patients who have had repeated fit testing, you need to know the results. If they were positive, some people feel like once they're positive, you don't offer them any more screening. I personally think that it's reasonable to offer more screening if people have not had a colonoscopy, but you need to try to get them in for that colonoscopy. We'll talk more about that later. Family history is a challenge. I'm going to talk about the Kaiser program in a few minutes. People always say, we don't want to send a fit kit to somebody who has a positive family history of colon cancer because they really should be screened by colonoscopy. But how do we know who has a family history? And is it better to offer screening with fit than to not offer anything at all? We also have to deal with competing comorbidity and symptoms, and identifying those comorbidities and those symptoms is challenging from a programmatic level. We have patients who are moving in and out of healthcare systems and changing insurance plans. And so how do you track this? My wife works for a major insurance carrier now, and they have large employers who look at their colon cancer screening rates and they say our rates are low. Tech companies say, only 40% of their population is up to date with screening. But what are they basing that on? Do they know about colonoscopies that might have occurred before the patient was employed or their member was employed by that organization? We really don't have any kind of screening registry to keep track of who's had a colonoscopy, who's had a normal colonoscopy, who has adenomas, need follow-up, et cetera. And standardization of family history collection is non-existent. The medical record systems really do not have a way to track family history. If you look at some data from the University of Colorado, where Dennis Anand and Swati Patel interviewed about 140 individuals who are high risk, they have advanced polyps diagnosed before age 60, they interviewed them to see what they understood about their history. Now, it's important to know that if somebody has this history of having early onset advanced neoplasia, the guidelines recommend that their first degree relatives get a colonoscopy starting at age 40 and repeated every 5 years. But what they found in the survey was that the patients themselves didn't even realize that they had high-risk lesions. So if the patient doesn't know they have high-risk lesions, how can their family members know that they're at higher risk and should be screened differently? So how can we develop a system to prioritize those patients for colonoscopic screening? We have to do better. We have to find a way to track family history and get these people in for the higher risk surveillance that they're due. We also find that we're overusing colonoscopy in patients who are unlikely to benefit. This paper just came out a couple of weeks ago from Audrey Calderwood in Dartmouth, where she showed, if you focus on the left, patients with no significant findings on colonoscopy, of those in the light bar with less than 5-year life expectancy, 60% of the time, the endoscopist is recommending a surveillance exam. They are very unlikely to benefit. This number should be much closer to 0. Now let's move on to how to offer screening. If you look at Kaiser data, and I'm going to focus a lot on Kaiser because I think that they are the model for us in the United States on programmatic colon cancer screening. TR11 is the director of their program, and he's done a fantastic job. If you look at the early 2000s, 40% of their population was up to date with screening. Sigmoidoscopy rates were falling from 30% down toward 20%, while screening colonoscopy rates were rising a little above 10%. Guaiac FOBT was essentially non-existent, and FIT was only a few percent of the patients. What they did was instituted a national or a programmatic mailed FIT program for Northern California. They included members aged 51 to 75. It's about 550,000 individuals who they mailed them a letter to tell them that a FIT kit was coming in the mail. If they had concerns, if they had a family history, if they had symptoms, they should contact their PCP, addressing some of those concerns I outlined earlier. And they went from 40% to adding another 20%. So now they're at 60% of their population up to date with screening when they mailed that FIT kit. Then they did a robocall reminder, postcard reminders, secure messages and calls from the MAs, and some inReach during flu clinic, which I'll talk about in a few minutes, getting them ultimately to an 81% colon cancer screening adherence rate. So here you can see the impact of mailed FIT boosting their screening up-to-date rates quite dramatically. That program led to a spike in the incidence of colon cancer, as you would imagine, because the FIT kits were picking up a lot of preclinical disease. And in the blue bar, the blue graph here, you see that the colon cancer mortality rates have been falling at Kaiser from 2000 to 2015. And we can't take all the credit for this with the screening program. Some of this is our oncology colleagues doing a better job of treating cancers and surgeons curing cancers, but a lot of this is due to the screening effort. Now, patient choice is an important factor to keep in mind. In San Francisco, a good friend of mine and my former boss, John Inadomi, randomized clinics to offer fecal occult blood testing. This was a guaiac FOBT, or colonoscopy, or choice. And as you can see in the blue bars, FOBT got 67% adherence, colonoscopy got 38%, and choice got 69% adherence overall, with a mix between the two tests. Now, there was differences by race and ethnicity in which test people chose. And we're having a bit of a delay with the IT, I'm afraid, but among whites, you can see that 52% chose colonoscopy. Among African Americans, only 20% chose colonoscopy. Among Latinos, 24%, and among Asians, 33%. So there's racial differences in what was chosen. So I apologize, bear with me while the computer lags here. In the CONFIRM study, which Shanti mentioned earlier, we have randomized 50,000 veterans around the country to be screened with either colonoscopy or FIT. We're following them for 10-year to 15-year mortality and incidence outcomes. And we only include people who are at average risk, but they could have had prior screening. And we looked at prior screening by test used by race. So among whites, how many of them are up to date with screening or previously screened, and how many of them were screened by colonoscopy versus FIT, for example. And what you see here is when we look at an adjusted model for any prior screening test use, we see that women were more likely to have been screened, an odds ratio of 1.21. And by race, there was no significant difference once we adjusted for other factors like education, smoking, et cetera. But when we look at prior fecal occult blood test use, here we see that Blacks or African Americans were more likely, an odds ratio of 1.09, but significantly more likely to have had a prior FOBT than whites. However, if we look at prior colonoscopy, we see that Blacks and Asians were less likely to have prior colonoscopy than whites. Among those people who were offered participation in CONFIRM who declined to participate, we asked them why they don't want to be in a study that would randomize them to colonoscopy or FIT. And what we found was that overall, there was a general preference for non-invasive screening by FIT, but this varied by region. And you can see in the Northeast, the two prefers colonoscopy was very similar to prefer stool testing. But in the West, there was pretty dramatic difference in preference for stool testing compared to colonoscopy. So we see that there are differences by race and ethnicity in what tests were performed. We see that there are differences in preference based on John Inadomi's work, and here we see there are some differences by region. In Poland, they did a study where they randomized over 12,000 individuals to first only offer colonoscopy, and if they were non-adherent, then they offered colonoscopy again, or they offered colonoscopy, and for those who are non-adherent, they offered FIT. Or in the third group, they offered a choice between the two, and 6 weeks later, again, offered choice. And you can see that the participation rates were highest for those who are sequentially offered two options or given choice at the outset. So let's move on to thinking about, is one screening test the best test for all individuals? You know, if would FIT be the best test for all? Would colonoscopy be the best for all, et cetera? I think it's important to take a step back and think about what the lifetime risk of colon cancer is. I told you it's the second leading cause of cancer death. It is common, but most people will never get it. 1 in 24 men and 1 in 25 women will get colon cancer in their lifetime. Ideally, we'd be able to figure out who that one person is and focus our screening on that person and not bother the other folks who are never destined to get it. We're not smart enough to do that yet, maybe someday. In Asia, they use the risk factors that I talked about earlier. Remember, I said 50% of the cases may be attributable to modifiable risk factors. So in Asia, they took age, sex, family history, and smoking into account. So only partially looking at modifiable risk factors with the smoking. And they risk stratified people into lower risk or higher risk. And everybody who was high risk went straight to colonoscopy. That was about 1,800 people out of 5,700. And the rest, the majority, they offered FIT. At the end of several years, they offered colonoscopy to everybody who had not yet had one to see what they missed. And what they found was that the vast majority of colorectal cancers and advanced neoplasia were found with FIT and colonoscopy in this strategy. So by risk stratifying people, you can focus colonoscopy on the higher risk people and do FIT on the lower risk people, and you will catch most of the cancers. 95% of the cancers were detected early. Some of the tests don't work as well in certain groups. In particular, sigmoidoscopy does not work as well in women as it does in men. You can see that the mortality reduction is 15% in women versus 33% in men. This is thought to be due to the general finding that women tend to form more proximal cancers without distal lesions that would be detected on FLEX-Sig. If a distal lesion is found on FLEX-Sig, then we generally do a colonoscopy. And in men, that tends to be the case, but not so much in women. So my take on this is that ideally we would have more personalized screening recommendations. Right now we say, as I showed you from the U.S. Preventive Services Task Force, screen people starting at age 45 up to age 75. We don't have a preference for one test versus another in their recommendations. But ideally we would be able to say, for this group, let's do aggressive screening with colonoscopy. For this other group, we could do non-invasive screening until, let's say, a certain age and then switch over. This introduces a level of complexity, however, and when guidelines get complex, adherence tends to fall. So there is a concern that this kind of approach would lead to lower adherence overall. So adherence is the key to colon cancer screening. I'm afraid I'm not really talking about the Nordic study, but I'll just take this as an aside. In the Nordic study, that was colonoscopy versus usual care, and they found an 18% reduction in cancer incidence and a non-significant 10% reduction in cancer mortality. But the key consideration there is adherence was only 42% with colonoscopy. Colonoscopy may be a great test at detecting and preventing colon cancer, but only if it's performed. And so we need to do better than 42% adherence. One way to improve adherence is to use an easier test. So if you compare the fecal immunochemical test to the guaiac FOBT, we see that there's an absolute increase of 9% in adherence. So you're asking a patient to do one sample testing with a fecal immunochemical test versus 3 sample testing with guaiac. So an easy intervention. Not many places are still using guaiac, but if they are, by switching to FIT, you'll get better adherence. We also can use reminders. In the VA and in Kaiser, we have reminder systems built into our medical records. I believe Cerner and Epic also have these as well. You can have a variety of different types of chart prompts, ticklers, and logs, and this has been shown to increase use of FOBT by about 14%. Outreach is also a key component of increasing screening. Now, this is getting back to the programmatic approach. Most individual clinicians are not going to they're not going to have the bandwidth to do outreach, and this is where programmatic screening comes into play. So if you just do usual care, you can expect from this study from Samir Gupta in Texas, about 12% of people will become adherent with screening over the following year. However, if you do outreach with inviting people for colonoscopy, they got 25% to be adherent. But if they did FIT outreach, they had 41% adherence. So FIT outreach has been shown to be quite effective at increasing colon cancer screening participation. Also, patient education improves adherence, and simple reminders improve adherence. In fact, in my VA, my colleagues in primary care just completed a study where they randomized people to get a no reminder or a text-based reminder or a robocall reminder. Just one text reminder or one robocall boosted the return rate of FIT by 10%. How about paying people to get screened? You know, we heard about this during the pandemic, people getting paid to get their COVID vaccines. People have been doing this for a long time to pay people to return FIT kits or come in for a colonoscopy. And you can see in this meta-analysis at the bottom that there was a 25% increased odds of getting screened if you pay people. So that sounds like that might be worthwhile, but there's more to the story here. When they break it down by the income of the people that were being offered screening, the benefits were greater in people who made more money than in people who had lower annual income. Also, the more diverse the population that was being offered the financial incentives, the less effective the incentive works. In other words, it was most effective in wealthier, whiter populations. When Rachel Asaka and I wrote an editorial on that meta-analysis, we kind of broke down some of the key points here. So financial incentives would increase stool-based testing by 3%, 3.5%. I mean, that's nothing to sneeze at. It's also not dramatic. So if you're not spending a lot of money, maybe it's worthwhile. All right, the system is still pausing on me. So, but again, the benefits decreased as the socioeconomic status increased. It decreased as you had more racial ethnic minorities. And also, I didn't mention this before, as the proportion of people overdue for screening increased, the financial incentives were less effective. And also when they were focusing on short-term outcomes. So really what it sounds like is that offering people $5 or $10 or $20 to return a FIT kit was nudging people who were going to do it anyway. They were already going to complete the FIT test, but now you gave money to return it sooner. There's also considerations from a behavioral economics perspective. So I've talked to some behavioral economics experts about this topic, and they're very concerned that when you pay people to do something that has intrinsic value, you minimize that intrinsic value. People should get screened for colon cancer to prevent colon cancer death and cancer incidence. They shouldn't get screened for money, because if you do pay them now, if you pay them to do a FIT test today, a year from now, when you send them a FIT test, they're going to say, how much are you going to pay me now? There's inflation, you need to pay me more. And we don't have systems in place to keep paying people for screening behavior. We're minimizing the intrinsic value. So I think it's a dangerous path to go down, and overall I would recommend against going down the path using financial incentives for health behaviors. What really works well is patient navigation, and there are multiple studies on this topic, but it takes resources to invest in having people offer screening and navigate people through the entire screening process. If you look back at that John and Adomi study from San Francisco I mentioned before, the left-hand part of this graph is the initial screening I mentioned to you before, FOBT in the light bar, and then colonoscopy in the darker bar. When they looked at subsequent years, in year 2, without any kind of clinic navigators to help people do their FITs, the adherence rates fell to 27% and 14%. Now, I alluded to InReach and FluFit programs before. What they've done in Kaiser to make sure that they get high rates of screening participation is when people come in for a flu shot, they look at their screening record, and if they're not up to date with colon cancer screening, they offer a FIT kit. And you can see in the top row here that boosts the completion of screening with FIT from 12% to 27%, overall a 15% increase in their population being up to date with screening in this one study. So there's a number of interventions that we can use to increase adherence. This slide summarizes the outreach, navigation, et cetera. You can see the effectiveness from an odds ratio of about 2.2, the patient education only an odds ratio of 1.2, but still there's a lot of different things we can do to boost adherence. I'm going to shift gears a little bit now. I've mentioned FIT a number of times, and I'm going to show you the Kaiser program in a few minutes, but FIT has its own set of challenges. FIT is a test for human hemoglobin. The patient collects a sample, puts it in a kit, mails it into the lab, and while that specimen is sitting there waiting to be processed, the hemoglobin is degrading. The longer it sits, the more degradation there is, as you can see here. Now, the threshold we use for calling a positive result with the most common test is 20 micrograms of hemoglobin per gram of stool, shown by the red dashed line at the bottom. And you can see that patients with cancer tend to stay above that, patients with advanced adenomas tend to stay above that, but patients with minor adenomas tend to fall below that over 14 days or so of follow-up. So the test is, by FDA clearance, it should be tested within 15 days of collection. Not only is it time sensitive, it's temperature sensitive. So here we see data, again from Kaiser. The peach bars are showing you the min and max temperatures in California, and the black line is the positivity rate. So you can see when it gets warmer, the positivity rate goes down and vice versa. So Georgia tends to get pretty warm in the summer. And so if you were to do a FIT program, it's probably best to consider avoiding use of FIT in the warmer months. Nobody's ever shown that the test accuracy actually is impacted by this, or the outcomes are really impacted by this. But you know, if you're designing a program around mailed FIT, it may be relatively easy to just avoid the several months when it's the warmest and focus on the fall and winter months. In the confirmed study which Shanti mentioned, we have looked at some of our early data and we see that our positivity rate falls in the summer from about 7% to below 6%. Now, when people are FIT positive, they need to have a colonoscopy. And we do have problems in this area. A significant proportion of people do not end up getting colonoscopy. And if you delay the colonoscopy, we see in the green box that when the colonoscopy is delayed beyond 6 months, we see that there's a higher risk of any colon cancer being diagnosed, and in red, advanced stage colon cancer. So we urge patients to come in for colonoscopy within a few months of the positive result. And here we see from Italy a nice study where they looked at compliers with colonoscopy to non-compliers, and you can see that those who comply have about a 4% chance of being diagnosed with colon cancer with a relatively flat curve after the first year, whereas the non-compliers, as you would expect, are being diagnosed with colon cancer over time, and the two curves cross. I think a good takeaway message to give your patients is based on the right-hand side of the slide, which focuses on cancer mortality, that people who are FIT positive who undergo colonoscopy have half the rate of death from colon cancer over the next 10 years compared to those who don't undergo colonoscopy. Now, here's some VA data that, I was always kind of ashamed to show because it shows a lot of variation in rates of colonoscopy after a positive FOBT within 6 months. These are, over 150 different medical centers. And you can see that our best centers get close to 100% colonoscopy rates, but some centers are down around 25%. And I thought maybe this is something unique to the VA, but just very recently, this paper came out of Optum, so privately insured patients, and you can see that their data looks very similar to our data with rates from 20% to about 75%. So there's a lot we can do to increase adherence with colonoscopy after FIT. In my VA, I started this program years ago where we just did a simple note in the medical record. I had one of my staff members write a note in the medical record that says, Mr. Jones is FIT positive. I will A, order a colonoscopy, or B, not order a colonoscopy because, and left it blank. And then we changed the name, the author of that note to whoever the PCP was responsible for that patient. And then they would get a view alert that says they've got an unsigned note, and they'd open the note like, oh, Mr. Jones has a positive test. Okay, what should I do? That simple intervention increased our referrals for colonoscopy by over 20%. We've looked at 300 patients who were FIT positive in the VA who had a documentation by the PCP that no follow-up is necessary. And we looked at the reasons that they documented for why no follow-up was necessary. And 1/3 of the time, we said the reason was good. 1/3 of the time, we weren't sure. 1/3 of the time, we felt that they made a bad decision. And these are the main reasons. The most common was they said the patient was too old to benefit from a colonoscopy, even though they were under age 86. I'm very suspicious of those cases. There may be some that might be appropriate, but they could have documented that comorbidity was the reason, and they did not. They said they had a prior colonoscopy more than a year ago. Well, if somebody had a colonoscopy, and sometimes it was 8 or 9 years ago, and they said, the colonoscopy said we were good for 10 years. Well, if they're FIT positive, you should repeat the colonoscopy or at least have a discussion with the patient and offer them another colonoscopy. In some cases, they said that a repeat FIT was negative. No number of negative FITs will cancel out a positive FIT. And in one case, they said there were no symptoms in the patient. Well, FIT is not a test, and it's a screening test. They don't need to have symptoms. Kaiser had about a 60 to 70% rate of getting colonoscopy done after a positive FIT, and they boosted that over 80% by doing a number of different interventions. There's no silver bullet, and you can see them listed here. Some common sense things like building endoscopic capacity, sending certified letters to FIT positive patients when they couldn't reach them by phone, removing the copay for colonoscopy, setting a target. Setting a target is really key for motivating staff and monitoring it. And then they had financial penalties for facilities that didn't meet the target. They made a registry of FIT positive patients for their staff to work on for navigation. And then they decided to take the primary care providers out of the loop. Anybody who was FIT positive automatically gets referred to GI. GI works on it, tries to get the person in, and if and only if they can't get them in, then they refer back to the PCP to try to get help. One of the major barriers to colonoscopy is transportation issues, especially for populations that are underserved. We see this in the VA, we see this in our county hospital. I suspect you see it as well. And my colleague at Harborview, our county hospital, has been doing research in this area. She's Rachel Asaka. She is looking at using Lyft Medical to provide door-to-door transportation, not curb to curb, but door-to-door, getting the patient from the endoscopy unit to their front door, and very good preliminary results with that. And hopefully she'll have more grant funding to study this. In the VA, we're looking at this as well. Now, whether you're doing screening colonoscopy or diagnostic colonoscopy, the quality of colonoscopy is paramount. And we talked about this a lot yesterday. I'm just going to touch on it briefly today. We know that the adenoma detection rate is associated with the risk of bad patient outcomes. So the higher the adenoma detection rate, the better the patient outcomes. Adenoma detection rate is the proportion of screening colonoscopies in which one or more precancerous polyps is found. And here we see data from Kaiser, where they divided the endoscopists into quintiles. And you can see at the top, the adenoma detection rates, that's that proportion of screening colonoscopies where an adenoma is found, ranged from 7.4% to 53%. Every 1% increase in the adenoma detection rate was associated with a 5% decreased odds of their patients dying from colon cancer. So dramatic finding, dramatic impact. Recently, the Italian group just showed that this relationship also holds for FIT positive colonoscopies. The ADR I used before was screening colonoscopies. These are FIT positive adenoma detection rates, and they see the same relationship. The doctors who find more adenomas protect their patients from getting colon cancer in the future. We know that doctors can do more to deliver high quality exams. Part of the equation is how much time they spend looking for polyps. Ozma Shalkut published this very nice paper from Minnesota, looking at 51 gastroenterologists, and looked at how long they spend pulling the scope out. That's the part where we examine the colon from the cecum back to the rectum. How much time they spend looking on average when no polyps are found. So every doctor gets an average withdrawal time, and you can see the doctors with withdrawal times over 9 minutes have a relatively low rate of interval cancers, that is post-colonoscopy colorectal cancer. And as the withdrawal time shortens, you see an exponential rise in that risk of interval cancer. Now, I want to spend a few minutes talking about disparities in colon cancer screening and outcomes. We know that there are disparities in colon cancer incidence and mortality. Here we see data just from, this is in press from the American Cancer Society, and we see that American Indians and Alaska Natives and non-Hispanic Blacks have significantly higher colon cancer incidence and mortality than non-Hispanic whites. We also know that this is not just based on stage of diagnosis. Survival among Blacks is lower, even when you stratify by stage of diagnosis. So there's a problem here. We do have some good news in that the rates are declining. I told you before that colon cancer rates are declining overall, and you can see in the lavender diamonds here that among Blacks, the rates are falling at a somewhat steeper slope than for other groups. And so the disparities are narrowing, but there's still disparities, and we need to worry about that. We need to address that. When we look at our progress to the Healthy People 2020 targets, this was published a few years ago. In the open circles are the 2007 rates of screening. In red is a screening target missed, and in purple, a screening target hit. And you can see we missed the target for all groups except those with an advanced degree, but you can see that worse screening rates for Blacks, Asian Pacific Islanders, American Indians, Alaska Natives, and Hispanics here in the second portion of the graph. When we look at cancer deaths, we see a little bit better news. We're hitting the target more often, but we do miss the target in men, and we miss the target in Blacks and in rural Americans. So a lot of work to be done. Now in the VA, I'm proud to say that we seem to be doing well in this regard. Fola May from the Los Angeles VA has this very nice study a few years ago and found that actually Blacks had an 18% higher adjusted odds of being up to date with screening. Hispanics were also more likely to be up to date with screening than white veterans, and as were Asians, but American Indian, Alaska Native veterans much less likely to be up to date with screening. This study came out from the American Cancer Society a few years ago and looking at interval cancer rates by race and ethnicity, and you can see that Blacks have a higher interval cancer rate than whites, and they also found that Blacks were more likely to receive colonoscopy from physicians with a lower polyp detection rate. So that's an interesting finding. It's a concerning finding. I think there's more work to be done to understand this better. and maybe we'll have time to discuss that if people have comments or questions. But nevertheless, the higher interval cancer rates, and I talked about interval cancer being associated with adenoma detection rates. So we need to improve the quality of colonoscopy in all groups, but it looks like especially for Blacks getting colonoscopy. Now, Chaik Debani looked at data from Kaiser coming back to that program that was instituted in 2006 and looked at racial disparities in colon cancer outcomes. This was just published in the New England Journal last year, and it's fascinating because what they're showing is that the disparities seem to have resolved by around 2018, 2019. Now, is this due to the screening program that I described earlier, or is it something else? It's, we can't prove it from this, but it's interesting that they have seen that dramatic improvement in those disparities. Now, I want to spend the last couple of minutes talking about the VA's approach to organized colon cancer screening. So as I said, we've got over 1 million veterans who are due for screening. There's no way we can do colonoscopy on all of them. The CDC and Kaiser and others were called to Atlanta in 2019 to develop a plan for mailed FIT. I was part of that meeting, and as were some of the other individuals I mentioned earlier, like TR Levin and Rachel Asaka. And one of the products of that was a mailed FIT implementation guide produced by the CDC, Kaiser, some VA representatives, and others. And what we did was I asked them if they would let me modify that document for VA purposes. And we have done that. We've created a document that I'm showing you the summary of here. It goes through all the steps of developing a national program or a local program for mailed FIT. How you get ready, how you select your FIT, how you execute the program and population selection, et cetera, and then how do you sustain the program. So we produced that document a few months ago. We developed a cohort identification tool. We call it the Mailed FIT Kit. And what it does is it looks through all of the veterans. So I ran this for Atlanta. We have 366 pages of veterans at the Atlanta VA who look like they're due for colon cancer screening with FIT. They seem to be appropriate. They're the right age. They're not up to date with screening as far as we can tell. I don't know about family history. We exclude anybody who had hospice. We exclude people with inflammatory bowel disease or prior history of polyps, et cetera. And we have this report that can then be exported to create a mailing list, a production list to send FIT kits. And our colleagues in Northern California piloted this. They have the mailed FIT program team that identifies the veterans. They send a primer letter out that says, according to our records, you're due for screening. We're going to send you a FIT kit. If you're concerned about this, if you've previously been screened and we don't know about it, call your doctor to talk about it. We then have a contract with the government publishing office. So we give them that list, 366 pages of veterans if we wish. And the GPO, for about $8 a pop, will mail FIT kits to those veterans. We batch order FIT kits to be tested in the lab. The veteran gets the kit. They hopefully will collect a sample, send it to the lab, we'll analyze it, notify them of the results. If they don't return it, we use a robocall system to deliver 2 reminders. And everything in red is part of the mailed FIT program, different than handing a kit out in clinic. And on the first 10,000 or so patients in Fresno and Vegas, they got almost a 50% return rate and abnormal results in about 7%. Primary care loves this. It's one less thing for them to worry about in clinic. They can focus on the patient's diabetes or hypertension or whatever else is going on because we've removed screening from their list of things to do. Now they can still talk to the patient about screening if they want. If they want to offer screening colonoscopy, they can do that. We've won a couple of awards for this program from the American College of Gastroenterology and from the VA Shark Tank program. So it's going pretty well. We issued a memo a few months ago mandating that every region in the VA institute mailed FIT this year. So there's 18 regions, 2 facilities from each region at a minimum must implement mailed FIT by December of this year. Our focus on doing FIT testing is not unique. If you look at the National Health Interview Survey, notice that the colon cancer screening rates are actually a little higher in 2021 than they were in 2019. So this is still during the pandemic. And note that stool testing increased from 6.2 million to 9.8 million, while colonoscopy dropped by over 1 million. So there's already a shift happening to more non-invasive testing. Some of this is Cologuard. I'm sure you've all seen the commercials and maybe the Saturday Night Live Woody Harrelson bit, but non-invasive testing is becoming more common. Now in the VA, I'm very worried about the FIT positive patients who haven't had colonoscopy. So we've developed a process of care dashboard for FIT, and you can see we can track orders, FIT results, FIT positive results, those who've had colonoscopy. We can run these reports at every facility. Give me a second while the system lags here. And what you see at the bottom are the bar graphs for each year of the proportion who get colonoscopy within 6 months, 12 months, more than 12 months, or no colonoscopy. I want to get this 40 to 47% group down as close to zero as possible. And in the red box here, we can get a patient list. So you can run a report, you can find every patient who's FIT positive, hasn't had a colonoscopy, and you can give it to a navigator for them to call those patients and follow up with them. And that's what I hope we'll be doing as part of an organized screening program. As far as colonoscopy quality goes, we have a dashboard tracking colonoscopy quality, the adenoma detection rate that I mentioned. Here I'm showing you data for every region of the nation, those 18 regions, and looking at the adenoma detection rates over time. But we can drill down to the individual provider level. So here is some data. The system's lagging, I apologize. In 2019, you see this provider had a 19% adenoma detection rate. You can see this, each dot is a provider, and you can see they're an outlier compared to their peers, and we can intervene to retrain them or give them a different duty assignments if we can't get their colonoscopy quality up to the levels we expect. Now, we're far from perfect in the VA. We have some providers who are falling below the benchmarks that I think they should be meeting. But when we compare the quality within the VA to outside the VA, we find that the community care lags far behind what we're seeing in the VA. I'm showing you an example from Oklahoma, but we have studies from Los Angeles, Vermont, Pittsburgh, showing that colonoscopy quality is better in the VA than in the community. These are comparable populations, veterans who are sent to the community versus being done in-house for similar indications. We find more polyps. We find more polyps per colonoscopy. We find more sessile serrated lesions. We do a better job with documentation and a better job with appropriate surveillance. I hope that every community, whether it's the VA or private practice or academics, will institute colonoscopy quality assurance programs so that everyone is getting high quality colonoscopy. That's how we're going to make an impact on those deaths. So to wrap it up, if the system will let me, I'm listing my top challenges, and sorry, the mouse is just not responding. Here we go. So it was supposed to be animated backwards. So I'm going to start with number 8, resistance to non-invasive screening test options. You know, everybody in the GI world, thinks that colonoscopy is the best test. I'm a big fan of screening colonoscopy, but I think it's just not practical for population-based screening at this time. We need to do a better job of systematic collection of prior screening test results. I talked to folks from the CDC and the White House at the White House Forum a few weeks ago, the Moonshot Forum, about this, and there's interest in developing a registry. There's lots of barriers to that, but I hope we can solve those and working with Epic and Cerner and other partners. We have challenges with overuse and underuse of colonoscopy. There's the technical issues with home-based screening tests that I mentioned. Colonoscopy quality assurance is a passion of mine. We can and we need to do better. We need to do better at getting people in for colonoscopy after an abnormal FIT. Overall, you know, the US healthcare system is highly fragmented. It would be great if we can get a more organized approach to population health management. But first and foremost, we have disparities in colon cancer screening and outcomes. And if we can address these challenges, we can save those 53,000 lives. Thank you very much for your attention and your time.
Wow, thank you. That was fantastic. I learned a ton. And I am going to encourage people to either raise their hand or put questions into the chat. There are a variety of things that I was curious about, but it really shows the power of harnessing data systems to work for us in medicine, I think, which is something hopefully we're on the verge of doing better. This may be like a small question compared to what all you just told us about, but you know, and you mentioned it in a slide, but you know, there was an article in the New York Times that I saw yesterday about this question of escorts as being a major issue, keeping people from getting invasive procedures of a variety of types. And you mentioned sort of the study that your colleague is doing, looking at lift door to door, but you know, that's going to take a long time and it's going to still be a cost. Has there been thought to sort of doing, taking folks who don't have escorts early in the morning and letting them recover for longer? Or are there other solutions, for example, that might help with that challenge? Because for my patients, that's a huge issue.
It's a great question. Yeah, so the VA put together a task force, social workers, anesthesiologists, gastroenterologists, et cetera, to look at this issue. It was like, there was this, it was colloquially called the no ride, no scope toolkit, because, you know, a lot of places, especially, you know, if you're a private healthcare system, people who don't have rides often don't have good insurance. So if you have a policy of no ride, no scope, that might be good for your bottom line. But for those of us who are taking care of underserved populations, that's just not tenable. We can't go that route. And, you know, the anesthesiologist may say no ride, no sedation. And I say, if you put up too many barriers to people getting scoped, we're gonna have bad outcomes too, right? We're all worried about somebody who will get on a bus and get off at the wrong stop, have something happen to them. Or, you know, I would not let them drive home. Driving home is not one of the options, okay? But people are worried if you put them in a taxi, the taxi driver may take advantage of them. If you put them in a Lyft, the Lyft person might take advantage of them. Well, the person, their friend or family member might take advantage of them too, post-sedation. We don't have control over that either. But it's concern about responsibility and medical legal responsibility. And I think we need to factor into that equation that not scoping them is going to hurt the population. And so we have a document, the American Society for Gastrointestinal Endoscopy actually has a document on this topic. One of the authors is a lawyer. It should be coming out soon. I'm one of the co-authors on it. I don't know when it'll come out, but check back in about 6 months on PubMed. I think you'll find it discussed in more detail. But great topic. There are some places I know that will say wait for 6 hours or 8 hours, then we'll let you get on a bus by yourself. Our county hospital does that on case-by-case basis.
Yeah, because again, to the disparity issue. Dr. Johnson, I see your hand raised.
Thanks so much. That was fabulous. I'm looking forward to reading the Calderwood article that you recommended. In my clinic of folks who are diagnosed with dementia or older, some of them are very attached to screening. And how do you nudge people off of low value tests?
Yeah, that's a great question also. Well, so there's some facts about colonoscopy. Like when I first started getting interested in colonoscopy, my mentor, Dawn Provenzali, who was a wonderful person, I said, we should do screening colonoscopy. She said, that's the most invasive test. Nobody screens with something like colonoscopy. This was 1996 or so. The risk of a major GI bleeding issue, 1 in 385. The risk of perforation, 1 in 2,000. The risk of a complication overall in the confirmed study, any complication, any adverse event is 3%, but a significant adverse event is 1 in 200. Okay, so, you know, I'm not trying to scare people away from screening colonoscopy, but when you're trying to nudge people, you might emphasize that a little more. You know, one of the things we do as gastroenterologists, we don't know what kind of health people are going to be in. So we might say repeat colonoscopy in 5 years, but when I say that, what I usually mean is reevaluate for colonoscopy in 5 years. And if their health has deteriorated, it's okay to say no. That's not a mandate that thou shalt do colonoscopy in 5 years. You can change your mind about that.
Well, I'm sad to say that we are past the top of the hour. But again, really, thank you so much. This has really been informative.
Well, thank you for this opportunity. It's great having a chance to visit you all. And Emory, it was wonderful to see old friends and make new ones. Thank you.
Great. And the lag may have bothered you, but it actually didn't bother any of the rest of us.
Okay. Yeah, we had some IT issues, but I apologize, but thanks for that.